Welcome back to the Deep Dive. Today, we are getting into something really fascinating. Selective Estrogen Receptor Modulators, or SERMs. If you're studying for boards or, just trying to get your head around endocrine pharmacology, these drugs are, well, they're both brilliant and incredibly frustrating.
They really are. And to get SERMs, you have to start with the problem they were trying to fix. And that was the huge clinical dilemma with traditional hormone replacement therapy, HRT.
Right. For years, HRT was seen as this cure-all for menopause. It was great for short-term things, hot flashes, urogenital atrophy.
Highly effective. And the early observational data, it gave us so much hope for the long term. It suggested HRT could, slash the risk of osteoporotic fractures, maybe even protect the heart.
That was the dream. But then the reality hit when those hopes were tested in proper randomized controlled trials.
And it got much, much darker. We found that HRT came with these really serious, undeniable drawbacks, an increased risk of breast cancer, uterine cancer, deep vein thrombosis.
Gallbladder disease, too. And once the public, grasped those risks, especially the cancer risk.
Compliance just fell off a cliff. Of course it did. When the risk seems bigger than the benefit, people stop taking the drug. We saw adherence rates drop to as low as, 15% in some studies?
So doctors were left with this huge clinical void. They needed something that could keep the good stuff, the bone and lipid protection, but get rid of the catastrophic risks in the breast and uterus.
And that, right there, is the mission statement of the SERM, tissue selective magic.
So that's our mission for this deep dive. We're going to unpack how one molecule can be an agonist in one tissue and an antagonist in another. We'll go from the molecular targets, ER-alpha and ER-beta, all the way to how you actually use this in the clinic.
Sounds good.
Okay, so let's start at the very bottom with the receptors. For a long time, the world only knew about one, right? Estrogen receptor alpha, ER-alpha.
That's right. And then the discovery of a second one, ER-beta, it just changed everything. It completely rewrote our understanding of estrogen signaling. SERMs only exist because these two receptors are not identical.
So where's the key difference? What allows a drug to tell them apart?
Well, you have to look at the two main parts of the receptor. The DNA binding domain, the DBD, is almost identical, over 90% the same.
So they grab onto the same bits of DNA.
Exactly. But the secret is in the ligand binding domain, the LBD. That's the pocket where the drug itself actually docks. And that region only shares about 55% homology.
Ah, so that's the opening.
That's the molecular playground for drug design.
Yeah.
It lets us create a key that fits, but maybe turns the lock in a different way or fails to turn it at all, depending on which lock it's in.
So how does a SERM actually flip that switch? How does it pull off being an agonist in bone and an antagonist in the breast?
Okay, so it all comes down to this one little structural piece called helix 12. Think of the LBD as a kind of sophisticated trap. When natural estrogen binds, it fits perfectly.
And that lets helix 12 fold down like a lid.
Yes, exactly. It closes the lid, and that creates a perfect surface for coactivator proteins to bind. We call it the AF2 site.
And those coactivators are the gas pedal for gene transcription.
Precisely. That's agonism. Now, a SERM is different. It's designed with this bulky side chain. Imagine a key with a giant clunky keychain attached.
Right.
When the SERM gets into that pocket, that big keychain gets in the way. It physically forces helix 12 to stick straight out instead of folding down.
So it's propping the lid open and blocking the coactivators from landing.
It's blocking the entrance. That's the basic mechanism of antagonism. But it's actually even more clever than that because it's not just about blocking, it's about who you invite to the party instead.
The co-regulator.
The co-regulator. So a SERM doesn't just block the gas pedal, the coactivators. In some tissues, like the breast with tamoxifen, it actively recruits the brakes, the core pressors.
Like NCOR?
It's like NCOR. And these core pressors actively shut down the signal. So the final effect in any tissue really depends on the unique ratio of ER-alpha to ER-beta and the local soup of coactivators versus core pressors in that cell.
And that's not just theoretical. That ratio has huge clinical implications. You see it with compounds like the phytoestrogen genistein.
Absolutely. It has a 20-fold higher affinity for ER-beta. And this is where the field is going. These fourth-generation SERMs like EM652, the goal is to create a pure anti-estrogen, something that blocks both AF1 and AF2 functions on both receptors, no matter what the tissue context is.
A universal off switch.
That's the idea.
Okay, let's bring this into the clinic, starting with the cornerstone application for SERMs breast cancer. Tamoxifen has been king for, over 20 years?
Oh, at least. And its anti-estrogenic effect in the breast is just incredibly powerful. The NSABP P1 trial was the landmark. It showed tamoxifen cut the risk of a new cancer in the other breast by almost half, 47%.
But we also see resistance, a lot of it. If the drug is just blocking the estrogen receptor, how do cancer cells get around that?
It's usually growth factor crosstalk. I mean, there are other signaling pathways in the cell that can just override the blockade. The classic example is HER2. If a tumor overexpresses HER2, it's getting this massive grow signal that's completely independent of estrogen.
So the cancer finds another fuel line.
It finds another fuel line, and tamoxifen's effect becomes much weaker.
Okay, that makes sense. Now let's talk about tamoxifen's biggest liability, the uterus. It's an antagonist in the breast, but it acts like a mild estrogen in the endometrium.
And that's the critical trade-off. It acts as a partial agonist there, and that leads to a significantly increased risk of endometrial cancer. The relative risk is cited as high as 7.5 in some studies.
And that's because of its structure, right? It doesn't fully block all activity.
Exactly. Even though it blocks that AF2 site we talked about, it still allows for some AF1 activity, which is enough to cause proliferation in the uterus.
Which is precisely the problem that raloxifene, the second-gen SERM, was designed to solve.
It was a huge step forward for safety. Raloxifene has minimal estrogen-like activity in the uterus, and this is critical. It is not associated with an increased risk of endometrial cancer. That's a primary reason it's often preferred if bone health is your main goal and uterine safety is a top priority.
So it's really the ER-alpha receptor driving those bad uterine effects. Does that receptor dominate other reproductive functions too?
Oh, absolutely. The knockout mice models were very clear on this. Mice without ER-alpha, the alpha ERCO mice, they're sterile. Huge reproductive and behavioral problems.
And the beta knockout mice?
They're mostly fine, relatively normal fertility and behavior. It really showed us that ER-alpha is the master switch for most of the classic reproductive functions.
And this wasn't just in mice. We saw this in a human case, right?
Yes, a fascinating case. A male patient who had a mutated ER-alpha gene. He had low bone density, but also his long bones never stopped growing because his epiphyseal plates never closed. It was this one singular case that just perfectly underscored how vital ER-alpha is for human bone maturation.
Well, that's a perfect transition to bone health because this is where SERMs are consistently good guys. They're agonists.
And we need them because estrogen deficiencies is just devastating for the skeleton. Postmenopausal bone loss is fast, and it is severe. SERMs exert a protective estrogenic effect.
Like raloxifene.
Raloxifene is the prime example. It's approved for osteoporosis prevention and treatment. The Moore trial was a landmark there, showing it cut the risk of vertebral fractures by 30 to 50%. It really works.
Is it all ER-alpha doing the good work in the bone?
It seems to be the main driver, yes, for stimulating bone growth, but it's complex. There's some evidence that ER-beta might actually play a role in suppressing osteoblast activity.
So the ideal drug might turn one on and the other off.
Potentially.
Yeah.
A selective agonist for alpha and an antagonist for beta in the bone. That's a future goal.
Let's pivot to cardiovascular health.
Oh.
This whole area is so messy because of those early observational studies we mentioned. That idea that HRT cut risk by 50%.
And we all learned a tough lesson there about correlation and causation. Those studies were just riddled with healthy user bias.
The women taking HRT were already healthier to begin with.
Exactly. They were exercising, eating well, seeing their doctors. It probably wasn't the estrogen driving the benefit, it was their lifestyle. Because when the intervention trials were done in women who already had heart disease, the benefit vanished.
So what do SERMs consistently do for the vascular system? Is there a clear benefit?
There is a clear benefit on one important marker, lipids. They have a favorable agonist effect on the lipid profile. Tamoxifen, tamoxifen, raloxifene, they all significantly reduce LDL cholesterol, the bad cholesterol.
By how much?
Tamoxifen can drop LDL by 20 to 30%. It's a substantial effect.
Okay, so if heart disease is the #1 killer of women, is there a SERM that has a specific edge in managing those risk factors?
There is, and it's raloxifene. See, traditional HRT and tamoxifen too can actually increase triglyceride levels, which is another major risk factor for heart disease.
But raloxifene doesn't.
Raloxifene does not increase triglycerides. So for a patient who's already at high risk for cardiovascular disease, that's a really important distinction. It's a major clinical advantage.
But despite the good news on lipids, there is one big systemic risk that none of these SERMs seem to be able to solve.
Unfortunately, yes. And that is the increased risk of venous thromboembolic events. DVT, and pulmonary embolism.
And that's true for both tamoxifen and raloxifene.
Both of them. The risk is comparable to what we see with traditional estrogen therapy. It suggests that the mechanism is systemic, probably related to agonist effects in the liver where clotting factors are made. It's a risk we haven't been able to engineer out yet.
Okay, let's touch on our last area, the central nervous system. We know estrogen is profoundly important for the brain.
Absolutely critical. For memory, cognition, neuroprotection. It helps build synapses in the hippocampus, and when estrogen levels fall, brain aging seems to accelerate, and the risk for Alzheimer's goes up.
And here we go again with the observational data suggesting HRT helped.
Right, a 50% risk reduction was suggested. But just like with heart disease, when they tested estrogen in women who already had Alzheimer's, there was no benefit.
Which led to this idea of a window of opportunity.
Exactly. The theory is that estrogen is protective. It maintains the brain's hardware. But if you wait until the disease has already taken hold and the damage is done, it's just too late to intervene. The window has closed.
This creates a really difficult clinical conflict then.
Yeah.
If you put a patient on a SERM for breast cancer prevention, you know it's acting as an anti-estrogen in the brain.
Right.
Are you potentially pushing them closer to cognitive decline, or AD, especially if they're already at risk?
It's a tough calculation. You are trading a very real, quantifiable reduction in cancer risk right now for a potential theoretical CNS risk down the road. It requires a very careful, individualized discussion with the patient.
Before we sum up, what about phytoestrogens? Patients ask about these all the time. They're marketed as nature's SERMs.
Yeah, that's really misleading. At the concentrations you get from food or supplements, they're not true SERMs. They act mostly as very weak estrogens, weak agonists.
And they prefer ER-beta, right?
They do, but they aren't a reliable substitute for therapy. In fact, we generally discourage patients on tamoxifen from taking them because they could theoretically interfere with the drug's anti-estrogenic action.
So putting it all together, SERMs are this incredible feat of molecular engineering, but they are absolutely not a magic bullet.
Not at all. That's the main takeaway. It's all about context. The receptor ratio, the coregulators in the tissue, that's what decides the outcome. Tamoxifen is great for the breast, but bad for the uterus. Raloxifene fixes the uterine problem, but they both still carry that VTE risk.
So the choice for a clinician has to be intensely personal. It's a detailed risk assessment for that one specific patient in front of you. What are they most at risk for? Breast cancer, fracture, heart disease.
Exactly. And the search for that truly ideal SERM, the one that's an antagonist only where you need it and an agonist everywhere else, that's still the holy grail.
All right, so for everyone listening, especially those of you in the medical field, here's a quick application question to tie this all together.
Okay. Imagine you have a postmenopausal patient. She's at high risk for both breast cancer and she has established cardiovascular disease. You have to choose between tamoxifen and raloxifene. Which one offers a specific advantage for her overall CVD risk profile based on what we know about their different effects on lipids?
And think about that one key lipid measurement that really separates these drugs from older HRT.
The answer is raloxifene. While they both lower LDL, which is great, raloxifene has that distinct advantage of not raising triglyceride levels.
A risk factor that's often pushed up by traditional estrogen.
Exactly. So in a patient with serious vascular concerns, not adding to their triglyceride burden makes raloxifene a much safer choice from a cardiovascular standpoint.
And that's what makes this field so fascinating. That level of molecular detail translates directly into a decision that can change a patient's life. The journey to really map out ER alpha versus ER beta and design even better drugs is, well, it's far from over.